Good afternoon. I would like to welcome you all to this virtual session of the Diabetes Conference, which is, I think, partly in honor of my father's fifth anniversary, which falls tomorrow. Today, I'm very happy to introduce the speaker we have with us today, Professor Akhter Hussain, who is very well known to Bangladesh and to us and to our association. He's an old friend. He is now currently President-elect International Diabetes Federation. He is also the President of the Diabetes Asia Study Group. Professor Chronic Diseases Diabetes, Nord University, Norway. Guest Professor Medicine, Federal University of Sierra Fortaleza, and co-chair Center for Global Health Research, ADAS. Finally, he is the co-editor of Journal of Diabetology. With these few words, I would like to welcome Professor Akhter Hussain to our session.
Thank you, Hazrapa, for your kind introduction. And Douglas, you probably don't know Professor Hazra Mahatab. You can say that she's the mother of endocrinology when it comes to Bangladesh. So she is the great daughter of a great father, Professor Ibrahim, who actually created the Diabetes Association of Bangladesh. And actually, today's session is in his memory. And I'm really privileged to see two distinguished persons here, as Professor Hazra Mahatab and Professor Azad Sir, who is my mentor. And whatever I have achieved, so these two persons has contributed a lot in this journey. So with these words, so I can start my thing. My idea is to present diabetes and COVID-19, the global issues. That my experience. I think I will be talking mostly of my experience from what I have learned. It's an ongoing and it's a learning process, so that we all are learning. And so I will just introduce the things that I'm in the process of learning. The coronavirus, it's not unknown to us. The virus was presumed to be zoonotic linked. We think that this comes from human or seafood, although there are some political rumors that this was created in a kind of laboratory and things like which we don't know. But what is mostly, we assume that this is zoonotic linked. The coronavirus belongs to the RNA virus and widely distributed among humans. So it has been this virus stayed amongst us for a very long time. Although most human coronavirus infections are mild, major outbreaks of two beta coronavirus, the severe acute respiratory, the SARS-CoV in 2002, that killed about 1 out of 10 infected, which is about 10% prevalence rate or mortality rate. And then it came the MASH in 2012, where the mortality rate was much higher. It was about 36%. But with COVID-19, actually the mortality rate is much lower. Globally, we are seeing at 3.2, which I have estimated today globally. Of course, there are large variations, but globally we see that the mortality rate from COVID-19 is actually much lower compared to the other two outbreaks that happened in the past. But what is so important in this COVID-19, that it is spreading faster than any other virus before. So the homogeneity of the receptor binding domain between SARS-CoV, SARS underlines the overlapping of pathogenicity and the biological properties. Indeed, the clinical manifestations of radiological features of COVID-19 and those of SARS are quite similar. So this is the way that we think that it comes from the bat, and for the SARS-CoV, it was transmitted through the camels to human, and SARS-CoV, so it was transmitted through the animal sources like monkeys. But with COVID-19, still is the question that where it comes from. But if you look at the symptoms, it's more or less the similar. We see the fever, the cough, headache, dyspnea, and tiredness. So the symptoms are similar. So I think that it will be rather difficult to present um, this that sorry. So in December 2019, this is a 2019, the cluster of pneumonia cases of unknown etiology broke out in Wuhan, in Wuhan. The sequence analysis from the lower respiratory tract samples indicated the novel coronavirus as the causative agent, which was named as severe respiratory coronavirus, and SARS-CoV-2, and the disease it caused is called COVID-19. The World Health Organization, WHO, declared it as a kind of pandemic. So if you look at this timeline, if you look at the timeline here, this timeline is described here. You can see that actually on December 8, 2019, the first case of SARS-related respiratory illness was reported in Wuhan. And then on December 31st, WHO is informed of the cases of pneumonia of unknown etiology. And in January 7, the novel coronavirus was identified and its genome completely sequenced. And in January 11, the report of the first death due to illness was caused by novel coronavirus. So January 30th, the WHO declares public health emergencies. And in February 29, the US reports its first COVID-19 death. March 11, WHO declares the COVID-19 as a pandemic. And March 23, the WHO Director General says COVID-19 pandemic is accelerating. But in good news is that March 24 in 2020, after a week with almost no new cases, China announces that Wuhan lockdown will be partially lifted on April 8th because this is free from corona. So it gives us the hope that it is possible to fight this virus. So if you look at this, for example, the global picture, as the way we see that, of course, we see that there are a number of cases. The highest death is in the US, followed by Brazil, India, Russia, Peru, South Africa, and Colombia. Bangladesh deaths is about 4,300. Of course, I know that people would disagree with the statistics, but I can assure you that the statistics from anywhere in the world in terms of this pandemic is influenced by politics. So it's not only in Bangladesh, it's not only in India, it's not only one country, it is everywhere. So we are fighting to have the good statistics, but every country is actually facing difficulties to produce the proper data because of politics, because of the diagnosis, that we are not being able to diagnose in time. If you look at this, for example, the case fatality rate, look at this case fatality rate, we see that, unfortunately, we are not seeing in Bangladesh is far on the right side. And Bangladesh is actually it's the lowest case fatality rate until now. Again, this is the question of statistics will arise. So there are many questions about the risk factors and outcomes in COVID-19 and diabetes, but the evidence is scarce. We are still gathering evidences, and therefore we said that it's a learning process. So first question that comes to mind, that are people with diabetes are at increased risk of infection of SARS-CoV-2? And does infection in people with COVID-19 yield a kind of more serious cases in people with diabetes? So these are the two questions that we are trying to answer, and I will try to shed some light on these two issues. So this was the first paper that we have published in COVID-19 and diabetes, knowledge in progress, that I said that is still that we are learning. And actually this was one of the first paper that came out as a kind of review, and this was taken up as it came as one of the top 10 articles in the whole world in terms of its references. So the thing is that the aim of this article was to aim briefly to review the general characteristics of the novel coronavirus and provide a better understanding of the coronavirus disease in people with diabetes and its management. So that's what we focused. So what we know that it is uncertain how long an individual with COVID remains infection. This is the first question: that what is the infectivity? What is the window of opportunity for us to identify and prevent? And this is uncertain, but what we know that it varies between 2 to 14 days. And we say the mean incubation period is about 3 days. But what we see that, for example, people with diabetes, actually, they have a shorter incubation period compared to the people without And this gives us one opportunity, because we have seen one study from China, which I was, that as probably most of you know, that the International Diabetes Federation took the initiative to arrange a special issue on COVID-19 and diabetes, and through the DRCP, Diabetes Research and Clinical Practice. And for this special issue, I was the editor for this special issue. So I read a large number of papers, and so I'm discussing some of those. One of the study that shows from China, it actually, they said the lymphocyte count in people with diabetes at the time of admission actually was higher compared to the people without diabetes. And that shows that probably the shorter incubation period gave us a better opportunity to treat the people with diabetes in its initial phase. And transmissions is more likely to occur in the earlier stages of the infections. And that we must remember, that if we're not able to identify in proper time very fast at the earliest stage, probably the transmission will already happen. And transmission from asymptomatic carriers to individuals within the inhibition period was found. Nevertheless, extent to which it occurs remains to be determined, because we see that it probably varies from societies to societies. So what are the symptoms that we see? That is the most flu-like symptoms: fever, fatigue, cough, congested pharynx, coarse breath without rays, headache, nausea, diarrhea, or dysgeusia, or sense or taste disorder, what we say. Some patients may develop acute respiratory disease syndrome, or we call it ARDS, arrhythmia, cardiac injury, shock, multiple organ failure, and death. So this is the clinical picture that we see for the people with diabetes. So if you look at this, for example, how this responds in its stages, you can put it in 3 different stages: stage 1, stage 2, and stage 3. That you see that the clinical symptoms over there is mild. In stage 1, we say the mild caution symptoms with fever, dry cough, diarrhea, or headache. But diarrhea is not very common that we see. And clinical signs is lymphopenia, is increased prothrombin, and increased D-dimer, and LDH. And in the second phase, that we say shortness of breath or hypoxia, and abnormal chest imaging. And in the third stage, that we are seeing that ARDS, or acute respiratory distress syndrome, and shock, cardiac failure. And if you look at the clinical signs, we say that elevated inflammatory markers, TRP, LDH, IL-6, D-dimer. So we see these markers that it has been elevated. So we can put them in 3 stages. As we know, that diabetes is already a growing burden across the globe, even before the COVID-19. We know that we are approaching 463 million people, and many of us will see that this is a conservative estimates. And we know that about 1 in 2 adults with diabetes remains undiagnosed, about 50%. So if we think, and 3 out of 4 people actually remains in low and middle income countries. And that's the problem, that our resources are constrained, our problems are bigger. So relationship of glycemic control to severity and mortality. So this comes to these questions. So we have very limited number of studies to date have analyzed the outcomes of glycemic control, mortality stratified on the level of glycemia in patients with diabetes and COVID-19. But however, these findings are based on very small number of cohorts. But in relatively large retrospective studies of 810 patients with diabetes in China, that we see that septic shock, ARDS, acute injury, and acute heart injury in patients with poorly controlled diabetes. So we see that there is a risk, but we also know that poorly controlled glucose will also increase the risk for heart, kidneys, etc. So this is a known factor. So how much is contributing with COVID is actually needs to be looked at. And then other question it comes to my mind that I would like to discuss with this, whether this is the cause or the effect. Because at the time, because most of these data were collected at the time of admission or during treatment. So if you see that, if you think the high viral load may interfere with the glucose hemostasis and thereby may heighten the blood glucose. So whether this is the effect of the virus or it is the cause for the severity or death, is still we do not know. And therefore, I think we need to do some future studies, as I'm putting a question mark with future studies. So risk of susceptibility. So first of all, we think that's what is the susceptibility risk for the people with diabetes. Data is showing that the risk of people with diabetes to be infected with COVID-19 is similar to the general population. Actually, we do not see any increased risk in its first phase. And the question is why? And we do not know actually why, but what we postulate that it is primarily infected through the upper respiratory tract. And therefore, probably the immunity doesn't have much to say about it. It is a rather receptor for the ACE2 for COVID-19 are responsible than, for example, immunity. So that probably one of the hypotheses remains and which needs to be investigated as well. So if we look at this, for example, the diabetes prevalence, what is the people with diabetes? It's about 9.7%. It's less than 10%, we are saying. And this is not higher than the diabetes prevalence of 10%. In addition to that, what we need to focus on that the people with those who are severe and death with COVID-19 is older people, is elderly population. And the diabetes prevalence in elderly population is about 20%. So it's about half, less than half of the prevalence that we would be expecting in this population in general terms. So we do not see an increased risk for susceptibility. And you can also look at this, for example, diabetes and non-diabetes, for example, fever, chills, chest tightness, or shortness of breath. In all these parameters, you see that the people with diabetes have a lower incidence. And this may also kind of make the clinicians more careful, because we know that people of diabetes, they present the case in a difference, because we know that, for example, chest pain in people with diabetes, they do not report a chest pain in terms of in case of any kind of infarction. So we need to be more careful and more vigilant, even though their symptoms are lower. So then it comes to who are at increased risk for severe illness. It's a 65 plus, pre-existing conditions, and what we know about patients with obesity. And this brings us another question, that most of the people with diabetes are also obese. So when we are looking at the people with diabetes and its risk, how we are excluding the risk of the obesity, because obesity will also have an effect on immunity alone without diabetes. So combining these two effects, so we need to look at that by saying that what is the independent risk of diabetes without obesity, which actually a matter of research again and to find it out. So risk for COVID-19 in people with diabetes for severity. So to date, the meta-analysis has calculated either relative risk and odds ratio found to be significant, about 2 to 3-fold increase. There is 2 to 3-fold increase risk that we see for severity and death. And the meta-analysis that I'm presenting here, it actually says that pooled analysis from 6 studies have shown the same thing. We have done one studies with my previous student, Hui Zhu from China. And these studies we have also published in Diabetes Research and Clinical Practices. This is a meta-analysis that we have done, and we see that there is an increased risk of about 3%. So yes, we know that when people are infected with COVID-19, they are at high risk for severity, and that we can say. So in terms of mortality, the Chinese Center for Disease Control and Prevention reported case fatality rate of 7.3% in patients with diabetes compared to case fatality rate of 2.3% of overall population. That again says that about 3 times more the risk. Now questions that why people with diabetes are at increased risk for severity. There are several factors. So I'm sorry that my slides are actually blocked by, yes. So I'll be talking this way. There are several factors, especially the impaired immune response. Diabetes increases the risk of infection in general, heightened inflammatory response, and hypercoagulable state, the role of ACE2 is for lung injury. And we have to say that, as I have started by saying, that this is a limited knowledge, and effect of anti-hyperglycemic drugs, angiotensin, that is the receptor, and the inhibitor, and the ARBs. So these are the possible areas for investigations. The clinical markers, when we see these clinical markers, that we see that there is significant decrease in lymphocyte, red blood cells, level of hemoglobin, and marked increase in neutrophils, erythrocyte sedimentation or ESR or D-dimer was observed in patients with diabetes compared to the cohorts without diabetes. In addition, a significant increase in alpha hydroxybutyrate, lactic dehydrogenase, ALT, CRPs, IL-6. So we see that there is an increased, there is a kind of differences between these people with diabetes and people without diabetes. What we find in the laboratory finding, we see that there is a decrease of blood oxygen saturation, decreased percentage of lymphocytes, decreased total protein and albumin, elevated serum glycated hemoglobin, and elevated ESR and CRP. This picture, if you look at this, for example, the lymphocytes, the neutrophils, the RBCs, hemoglobin, CRPs, serum ferritin, ESR. So you see that there is a marked difference between the people with diabetes among the patients. These are all patients. Among the patients with diabetes and non-diabetes, there is a marked differences in every parameter and every count. So there is no doubt that the diabetes is influencing the condition for the virus. So we are now moving to the treatment. So at the moment, the therapeutic strategy for COVID-19 is largely supportive. We do not have any effective treatment at this stage. Several off-lab antiviral agents seem to be clinically beneficial, but their efficacy is far from satisfactory. So that is the situation. So I will be going one by one. So we said that there is limited knowledge, as I have started with this in the beginning. The use of corticoids was studied in several clinical studies. Special caution should be taken for people with diabetes. When we are using corticoids, the people with diabetes should be especially taken care of. However, that dexamethasone, it shows that there is a reduced mortality in severe cases, but it was not found to be useful in less critical patients. So anticoagulation therapy can be introduced. The use of ACE2 inhibitors should be used with caution and should be followed up. The hydroxychloroquine in treating COVID-19 should be avoided. There is no scientific evidence for this whatsoever for the beneficial effect. So far, remdesivir has shown its beneficial effect to reduce hospital days. That means it seems to be more effective in people with non-severe cases, but not with severe cases. For example, those who are admitted, those who are admitted in the it's not found to be very effective for the mortality, for reduction of mortality. Now there is a big discussions about the plasma therapy. So what is the future of plasma therapy? You see that the use of convalescent serum was used from the late 90s. So it's nothing new. It is nothing newly discovered. In 1901, actually Emil von Behring was awarded the Nobel Prize for medicine for his work, which served as a basis for multiple diseases in 90s and also developed vaccines following the same theory. There is no solid evidence yet that the serum treatments are effective against COVID-19, but FDA has approved convalescent serum used in treatment for severe COVID-19 cases under compassionate use. So it needs to be careful, but we need to say that FDA's approval doesn't necessarily take the situation of Bangladesh. A small study in China found that the patients in plasma group had a shorter hospital stay and lower mortality than the control group, and no immediate adverse effect noted after plasma infusion. Our previous experience with SARS suggests that this plasma exhibit a neutralizing antibody response directing against the viral S protein. The viral S protein is the peak of the virus. This antibody blocks SARS-CoV ACE2 entry and can be detected even after 24 months after the infection. So it lasted for about 2 months. So how actually it says how this one works. If you say that, for example, this person that who is infected and recovered and there is no symptoms for 14 days, so these people can be actually donate their plasma, and which can be used for prevention, which is the model for example, vaccine, and for treatment. So you see that the patients with no previous exposure can be taken in, neutralization, and that will prevent. And in case of patients, so this plasma can be used in people who are infected, and hopefully that these antibodies will neutralize the SARS-CoV and then the clearance of the infection. So that is, in a sense, the theory for this. There are many trials are going on, and then we have to see carefully that how this can be done. Of course, it has some risk because some people are afraid that there are some diseases can be transmitted from the donor to the recipients. So if you look at the figure, so this therapy, the serum therapy, actually started in 1850 and largely used until the 1950. At the time when you have the introduction of penicillin, this has stopped because most of this viral infection or bacterial infection stopped with the penicillin, and then it started again. We see that it's in around 2000. So there are different recommendations, FDA recommendations of the use of titer of 1.60, whereas European Commission's recommendation is 1:320 titer. But we can say that in this sort of situations, the enemy of good is probably better. But what is worrying, though, if you look at this study, this was published in the New England Journal of Medicine, that we see that, for example, that you see that the immunity, actually, it doesn't last more than 3 months. So most of the immunity falls. So when you produce the antibodies generally doesn't stay long. So that means that even though we have this infection, it has the potentialities that you can be reinfected with the virus. That is one. Second thing is that when we have developed the vaccines to develop antibodies, we probably will have to think that probably it may not give you a kind of lifelong protection. You may have to take it, a booster dose, maybe after every year or so. So then going back to hydroxychloroquine. So hydroxychloroquine is a malarial drug that was developed in 1934, and this analog of chloroquine was developed in 1946. What are the recommendations that we face? The COVID-19 treatment guide panel that was developed by the WHO that recommends against the use of chloroquine or hydroxychloroquine for the treatment of COVID-19 in hospitalized patients. And this is in non-hospitalized patients, the panel recommends against the use of chloroquine or hydroxychloroquine for the treatment of COVID-19, except in clinical trials. The panel recommends against the use of high dose of chloroquine, that is 600 milligram twice daily for 10 days for the treatment of COVID-19. And the panel also recommends against the use of hydroxychloroquine plus azithromycin to treat COVID-19, except in clinical trials. So the panel is very clear that they do not recommend hydroxychloroquine for the treatment. Concerns are that there is an increased risk of hypoglycemia in patients with diabetes because hydroxychloroquine have a kind of effect on glucose metabolism. And there is a kind of QTc prolongation that is a ventricular arrhythmia and then cardiac deaths. It increases. In a large randomized controlled trial, hospitalized patients in the UK, those who received hydroxychloroquine were more likely to subsequently require intubation or die during hospitalization than those who received the standard of care. So we come to remdesivir. So remdesivir was originally developed to treat for Ebola virus, but proved to be ineffective. Remdesivir and other medications that halt SARS-CoV-2 virus replication may be more effective when used before severe lung damage occurs. That means that we have to, if you use it in the early phase, non-severe cases, this may be an effective drug. Later on, combining the antivirals with anti-inflammatory drugs, for example, Asametra, and that the control the excessive immune reaction known as cytokine storm might produce the best outcome. So this is this is still needs to be proved, which is not proved, but this is a hypothesis for treatment in combination with remdesivir. Dexamethasone that we started in, for treating ill patients, that corticosteroids are not generally recommended for treatment of viral pneumonia. The benefit of corticosteroids in septic shock results from tempering the host immune response to bacterial toxin release. For patients on ventilators, the treatment was shown to reduce the mortality by about 1/3. And for patients requiring only oxygen, mortality was cut by about 1/5, according to the preliminary findings from UK, and is shared with the WHO. So the benefit was only seen in patients who seriously ill with COVID-19 and was not observed in patients with milder diseases. And then SGL2, the main concern with the SGL2 is that it increases the lactic acidosis. And it also, and euglycemic ketoacidosis. So this has been exhibited, and UK is not now, it's not that there's an international ban, but UK is asking not to use SGL2 drug. So then ACE2, angiotensin converting enzyme, that what are the concerns? The concern are the overexpression of ACE2, and ACE2 is the functional receptor of SARS-CoV-2. So that means that if we give it, probably there will be the receptors, because of the overexpression of ACE2, probably they are more likely to be infected with COVID-19. So it is claimed that viral clearance is delayed by diabetes, hypertension due to increased expression of ACE2. And it is, so there are concerns, but we have no, you can say, scientific documentation that this is harmful. Metformin, and this is also this AMP activated protein kinase. So this can be antiproliferative and immunomodulatory, and therefore hypothetically should be avoided. But again, there is no scientific evidence to say that, to suggest that this is actually harmful. Pioglitazone has also have the same. These animal studies have suggested that increased ACE2 expression in liver tissues on the mechanism. And indeed, the purported increase of ACE2 with pioglitazone led to some researchers propose avoiding this drug in patients with diabetes. So this we need to see, and we have also seen this same situation with TZD when compared with the sulfonylurea. So there are some concerns on pioglitazone, but again, I said that we have not seen yet that any clinical studies where they're systematically showing any kind of adverse effect of using these drugs. Sulfonylureas, on the other hand, there is no concern over the overexpression of ACE2, thus theoretically no increased risk for COVID-19. However, hypoglycemia potentially warrants lower doses and needs to be followed up in order to avoid any hypoglycemia. So treatment with people with diabetes, so that means we say that avoiding metformin, SLG2, in particular in sicker patients with moderate to severe COVID-19, with an anticipation of increased lactic acidosis and euglycemic or ketoacidosis with both the drugs respectively. Some concerns in the light of interaction of angiotensin converting enzyme 2, that is ACE2 to COVID-19. So these are concerns since these anti-diabetic drugs have been associated with the overexpression of ACE2 in different human organs. So how then we care, how we control the diabetes care must continue. The continuation of regular medication, for example, we should follow the good control of hypertension, cholesterol, blood glucose are essential. Seek the rules that, as we said, that SGL2 probably should be stopped. If unwell, may need to increase the insulin and seek medical attention early for acute illness or diabetes complication, that is chest pain and food problems should be taken care of. Personal prevention, that good hygiene, that is hand wash, not to touch face, shower after going outside, social distancing 1 meter, mask applying, alcohol-based sanitizer that has at least 60% alcohol, good glycemic control, maintain physical activities, reduce stress, keep your diabetic medications available, seek help from friends, family to avoid closer contact for shopping, avoid if possible, public transport. So we see that there are the sick and older, the underlying health conditions, test, if someone is tested positive COVID-19, so then everybody should be go in quarantine, not gathering more than 10 people, stay 6 feet, avoid travel. So these are important things. We have also seen that where there is no prevention strategy, as we can see that you can say that USA and Brazil is the two examples, that the uninfected persons are being reduced, and infected persons is reduced when they are forced quarantine. But you say that modern social distancing, as we see mostly in the European countries, has also very good effect. Public health policies for prevention. The vaccine. There is currently no approved vaccine available to prevent COVID-19 infection, but some attempts are in progress, particularly from Russia, which I will discuss in the next slide. Diagnosis, tracking, infected persons, contacts, and isolation remains the major intervention policies. Increased diagnosis capacity, secure personal and protective equipment, PPE, to halt personnel, to the health personnel, training and educating public and healthcare personnel. Based on the WHO recommendations, any non-essential travel to high-risk areas should be restricted. Screening health status of travelers, healthcare workers, and other people with close contacts with confirmed patients is an efficient measure to contain the spread of infection. So these are the government policies. So vaccine, that's the Russian vaccine that we say, that it is safety, and it is this vaccine is a vector-borne, is vector-based, heterogeneous, it's primary to do both COVID-19 vaccine. And they have done 2 open non-randomized phase studies from Russia. The conclusion was that this is found to be safe, profile, and induce strong humoral and cellular immune response in the participants. All the participants that went through that had developed the antibodies. Further investigations is needed in order to assess the effectiveness of vaccine for prevention of COVID-19 too, because they have not done a kind of the so-called the phase 3 trial. So in phase 1 and phase 2, it seems to be safe, and it seems to have produced both humoral and cellular immune response in participants who have received the vaccine. So it is published actually yesterday in Lancet. So it's probably a good news that there is something is coming in. And when we say social distancing also is a kind of coping issue. It also creates kind of a stress, eating and physical inactivity, social isolation, and low levels of social support associated with increased morbidity and mortality. So actually it can increase a number of other problems. And therefore, the public health measures must include a community strengthening service. There should be an anchor organization. And then you can think that there should be clinical delivery systems. You have the community services for example, for ambulances, for food, for medications, etc. So that the people feel safe, people, even though they are staying at home, they should not feel isolated. That's the most important question, is how this pandemic might affect the diabetes management. And if you look on your left-hand side, it's the number of deaths and hospitalization. And these are the peaks at the time of COVID-19 and diabetes-related acute care intervention. So you see that is the peaks. So here is the diabetes-related chronic care for interruption. So if you follow this path, so you see that there is a possibility that there will be kind of lower possibility for the diabetes management due to this COVID-19. And this may be more true for people in the resource-constrained societies like Bangladesh. So then how do you manage the COVID-19? So these are the challenges that on your right-hand side, you can say patients have questions, usual clinic appointments, patients are afraid to seek help for diabetes complications due to COVID-19, patients are feeling unwell but do not want to leave home. What is the solution? The telemedicine. Assure patients of safe to go to the hospital if it is required, of course. Encourage patients to call the clinic with any concerns, and maintain open communication to help monitor for complications. So these are the solutions that we need to think. And what are the benefits of a telemedicine? The telemedicine, actually, it limits the face-to-face exposure. So that means you don't have to go provides personal connection with the patients, allows data for monitoring and review, allows treatment adjustments, and presents an opportunity for more patient education and gives patients more control over the diseases. What are the challenges? This is obtaining current data is not always possible. Patients may struggle with the technology, particularly in countries like Bangladesh. Not possible to conduct any physical examination. Patients responsible for reporting weight, blood pressure, etc., and which may not be always correct. And support staff is not easily integrated into care. And primary clinician responsible for more things than the telemedicine, so they may have very less time. We should continue with the routine vaccine as scheduled. There is no indication that we should not do the normal vaccinations, like, for example, influenza, pneumococcal, or other vaccination as indicated. BARDAS has produced a guideline which is found to be very effective, which is very important for people in Bangladesh to follow. This has been now published in the Journal of Diabetology, which is the official journal of the DASC, the Diabetes Asian Study Group. So I would recommend everyone to have a look on this. With this, I will go to the closing remarks. With closing remarks, I will say that at the moment, therapeutic strategy for COVID-19 is largely supported. Insufficient evidence to suggest an effective treatment for COVID-19, and especially in people with diabetes. Glycemic control is important, but remains unclear whether hyperglycemia in severe cases is a cause or an effect. Therefore, a special focus must be maintained not to risk hypoglycemic event to keep the normal blood glucose. So this is something that we need to think. Until today, we do not have any clinical evidence to suggest to stop angiotensin, the ACE2 inhibitor, or metformin, or pioglitazone for people with diabetes. Thus, SLG2 may be avoided. The hydroxychloroquine should be avoided. Remdesivir has shown its effect in milder cases for COVID-19 and should be introduced in the earlier phases of the disease. Dexamethasone has shown its effect in treating severe cases, so this can be used only patients in severe patients. Maintain your blood glucose, be observant for your complications, maintain physical activities, and continue routine vaccination, and adhere to the preventive rules. So with these words, I will say thank you for your attention. Thank you.